Good afternoon, and welcome to Optimizing Patient Throughput, Technology Strategies for Discharge Efficiency, a Health System CIO production sponsored by iHarbor, the University of Maryland Medical Systems Innovation Center. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health Systems CIO, and I will be your moderator today. We're looking forward to your participation. You can send in your questions or comments at any time in the Q&A box, and we'll take those later in the session. Just so you see how we're going to spend our time today, we're going to go about 35 to 40 minutes with our main panel discussion featuring Sunny Sapra, Chief Information and Technology Officer with UVA Health, Dr. Juan Rojas, Associate CMIO with Rush University Medical Center, and Warren D'Souza, SVP, Chief Innovation Officer at the University of Maryland Medical System and co-director for the University of Maryland Institute for Health Computing. And then we will have our Q&A. So let's jump right in. Sunny, let's start with you. Can you give me an overview of your organization and your role?
Sure, and thank you for having me on, Anthony. As mentioned, I'm Sunny Sapra. I'm the CIO at University of Virginia Health. I'll be candid here. I've been here just over 100 days, so very new to the organization and to the area. But the organization is large academic health center. We are now larger than the footprint we've had in the past. We've been very much focused on the Charlottesville area, but are now in the community health business as well, and have acquired some facilities that go all the way up to Northern Virginia. So we cover a population that is in and around of Charlottesville, but also all north of here as well. And our goal, honestly, is to take care of all Virginians, right? We are one of the larger academic health centers in the state here, with a pediatric hospital as well that is well poised to be known as the best pediatric health system for the state of Virginia. So that's a little bit about me. Again, been here over 100 days now, and then look forward to hearing some of my co-panelists here.
All right, very good, Sunny. Thank you. Dr. Rojas?
Yeah, thank you for the invitation. Look forward to a great conversation with my co-panelists as well. I'm I'm Juan Rojas. I'm an adult ICU and pulmonary doctor at Rush University System for Health in Chicago, but also wear the hat as one of the associate chief medical information officers for the health system. With my work really focusing on the intersection of sort of AI, data science, and informatics, and a lot of the new kind of things that health systems are worrying about and governing and turning on, and helping be part of the team doing that. Our health system, just a little bit about us. We are obviously in the Chicagoland area, like I just mentioned. We have one tertiary quaternary care center in the Chicago proper, and then have two community sites outside of the city with a variety of outpatient clinics throughout the Chicagoland area, kind of servicing, the counties around the Chicagoland area and a little bit of Northwest Indiana as well. So yeah, look forward to our conversation today.
Oh, very good. Thank you. Warren?
Good afternoon. Thank you for having me. My name is Warren D'Souza. I serve as the Chief Innovation Officer for the University of Maryland Medical System. We are a fairly large academic health system headquartered in Baltimore, Maryland, serving many of the citizens in the state of Maryland, anchored by a flagship academic medical center in downtown Baltimore, but with 10 other community hospitals serving many different diverse geographies in the state of Maryland, including the rural parts of Maryland on the Eastern Shore adjacent to Delaware. Roughly 29,000 employees with a mix of faculty physicians, employed physicians, and then other independent contracted docs. So as you can imagine, makes for a complex environment. And we are heavily matrixed in the way we operate, obviously has some implications for today's conversations. 29,000 employees that essentially are geared towards supporting diverse geographies, both in urban populations, suburban populations, and then rural populations.
All right, excellent. Very good. Let's jump right in. We're going to talk about patient throughput. And when we talk about patient throughput as a technology problem, organizations define the boundaries differently. Some focus narrowly on discharge coordination. Others extend the aperture to include ED boarding, PACU holds, ICU transfers, and post-acute transitions. How are health systems today scoping the throughput challenge from an IT and data standpoint? And what made you draw the lines where you did? So wherever you want to take that. Sonny, let's start with you.
Yeah, I'd say in at least in our organization and what I've seen in the some of the ones that I worked as well, it's really defining it as it's not just a movement of patients, right? We're really managing patient progression, and that progression, you're kind of working against discharge timelines. Which is a complex world, right? When you really are looking at it, there tends to center more about length of stay, performance, and discharge efficiency. But these metrics, they honestly they reflect patient experience and operational capacity, and that's where I feel like we're starting to put more of the tools to saying how do we actually support those areas, right? And how do you actually look at that patient progression that is not only from when that patient enters the door to when they leave the door, it's what's happening to them once they leave, what's happening to them before they come, even, right? And it's managing those pieces and trying to, from an IT perspective, honestly, this is where we really are stuck at the hip with our operational areas because there's so much there that happens from an operational perspective, and really looking at how do you actually how do you predict some of what's coming in the door, but also how do you actually manage what's happening in the doors, and then how are you actually showing them the predictive model of what happens once that patient leaves, and what is the likelihood of them coming back, and it becomes that whole progression side of things. And so I think we're looking at it a little differently. I think we're still in that maturity model of how do we actually make that effective, and I don't think we're unique in that situation at UVA Health. I see that across other organizations as we're trying to look at how where does IT play in that space there, and I hear more of that term of patient progression, right? Because it's not only what's in length of stay, which a lot of our metrics focus on that, but there's a lot that happens outside of that as well.
Excellent. Very good. Dr. Rojas?
Yeah, I'll just echo kind of what Tony said with my own, I guess, as the card carrying doctor on today's podcast. I think part of the issue with when we talk about throughput, I think as Tony mentioned, it's often working with your operational partners, and I think what happens is every operational partner has their own definition of throughput through the lens of which they care for patients. And what I mean by that is if you're an ER doctor, the only thing you really worry about is time from ER triage to getting into a bed or ER boarding. You may not necessarily have the same engagement as me as an ICU doctor on time in the ICU and then time leaving the ICU and then when you leave the hospital, right? So I think really for me, the things that people are really focusing on, for better or for worse, are things like Sonny mentioned, total hospital length of stay, ED boarding times, ED wait times. I also think they're increasingly a lot of, as we talk about care journeys, is the ER appropriate for your care journey? Or maybe there's an urgent care, maybe there is an outpatient offset valve that you can think through. And what I think we should be moving towards, as far as my IT hat, is how do we help our operational business clinical leaders who work under the auspice of their own preferred metric, and then think about a more cohesive plan above that. That's like, okay, that journey. So that way, Sunny can provide the tool stack that, the ER, the ICU, the ambulatory center may have different priorities, but they're still using the same tools that maybe now in a more AI-enabled world allow them to sort of think through a more cohesive journey together, even if they're not purposely doing it, right? Like I think it has to be sort of that's where I think IT can really help your business leaders have a mentality that's more 30,000 foot view than like right down in the weeds for everything. And I think you need those people who really care about like what is happening in the ER, because the reality is a lot of the problems that we have with ER boarding, length of stay issues are not something necessarily IT or technology can fix. It's a variety of problems, but I think it's really providing the toolkit in the mentality that it is more of a journey than it is just a isolated like problem on your own island. I think that's part of the issue in healthcare is that we just, well, at least on the clinical side, we often live on our own island and we don't think about the other islands that are part of your, the same hospital.
That's very interesting. Yeah, Warren, your thoughts?
So I agree with what Dr. Rojas and Sunny just echoed. I would define patient flow, or at least the perimeter of patient flow, to be all-inclusive of what you originally posited, Anthony. And I sort of think of this as one gigantic interconnected problem. So what we tend to do in the healthcare space is when folks are focused on particular domains, whether that's the ED or the PACU or discharging patients, you think of those things in isolation. And what I would posit is that all of those elements are heavily interconnected. What you do in any of those spaces has a either direct or indirect trickle down or trickle up effect in any of these other spaces. So the way we think about it, at least at the University of Maryland, is that you have to essentially think of the whole elephant here as opposed to parts of the elephant. And so when you think about solutions, when you think about processes, when you think about operational leadership and technology, it has to be an all-inclusive viewpoint, or else you have unintended consequences. And I know we'll get into some of that, but that's where we would sort of ring fence this, is to create the broadest sort of aspect associated with patient flow.
All right, Warren, let's dig in a little bit that in light of what our other panelists are saying. How much of what people need to or want to accomplish is metric driven, right? So each, Dr. Rojas mentioned every niche, every unit, every operating unit is driven by metrics that are defined by leadership, right? Here are the metrics. Some may be compliance, some are just standard across the board. So everyone's got their niche metrics they need to meet. Theoretically, that could be simple for IT to say, okay, we know what you're trying to do now. Let me see if we can layer in or integrate some technologies that'll help you achieve your metrics. Is that sort of where it all starts? And Dr. Rojas mentioned now, we understand that dynamic, but the enterprise IT has to come with the overarching vision. So I'm getting requests at a departmental level to support them in pursuit of their niche metric, but somehow I have to translate that into something that harmonizes across the enterprise, that is an appropriate spend and an efficient spend, and I'm not buying a whole bunch of different point solutions. I guess that's the art of where this comes in. Your thoughts?
Yeah, so I think it does start with metrics, and we've never been short on metrics in the healthcare space, right? So what I would suggest is that particularly in this space, in patient flow, there are the sort of legacy metrics, which many of them are highly relevant. I mean, length of stay is a appropriate and relevant metric. The question is, if you start with something like length of stay, which is more of a macro metric, how does that actually inform the deployment, adoption of technology, where length of stay is influenced by many different micro actions, including coordinating care, communication across diverse stakeholders, awareness of some of the barriers or some of the items to be done, anticipating in the form of various care needs that a patient might have, and then also addressing things like some of the structural deficits. If you're trying to discharge a patient to a SNF or a long-term care facility, it's a very different ballgame than discharging a patient to home. So it's fine to say, I want to look at length of stay and I want to prop that up on a dashboard, but the deconstructing that into all of the microfibers and the constituencies and all of the metrics that then potentially feed into what ultimately constitutes length of stay That's I think how you crack this nut, not simply by looking at the sort of the macro or the very downstream metric of length of stay.
So, Sonny, very interesting, right? We know that this makes a lot of sense. We've got metrics at the departmental level. You're being asked to help or how you can support their journey in improving their metrics. There's certain things that are going to be within your control and influence as an IT, enterprise IT leader. Tools, things like that. As Warren mentioned, there's going to be many things outside of IT's control that on an operations side they're going to have to figure out. But there are things you can do. There are tools they could have that they may or may not have, and that's your job. Your job is right to give them everything possible for them to succeed, and then certainly they can run with that. And but so much of that is out of your control. So actually moving that metric a good degree out of your control. But what are the things that you need to do to support the journey?
Yeah, and I'll take a little bit about what Warren said there, right? So when you think about this, the way I look at it is that you have to have that macro, right? There's no way of getting out of that macro picture. You need to see your length of stays, your discharge times, progression metrics. I mean, you're looking at all of those metrics pretty carefully. Now, the way I look at it, there's a tiered governance model, right? There needs to be where you've got that, steering committee, the operational work groups, they've got clinical nursing, operational leaders defining the workflows, and IT enabling the tools to be able to use in those micro spaces there. Now, where I feel like there's a level of maturity that still needs to happen, and that's, at UVA, and I think I'm in other organizations as well, is that when you are working in that tiered governance and you're looking at those micros, right, of what needs to impact the overall, how can we put predictive models to say if I change this here, and you're talking about changing this workflow within the micro of this larger macro here, what does that actually do to the length of stay? What does it do to some of the other areas that we're talking about? Because there are several layers to that. As mentioned, they are very interconnected, right? What may happen from moving a patient from one area in the hospital to another area to actually getting discharged, whether they're getting discharged to home or whether they're getting to SNF, it's a different, like, in some ways, overall metric that you're looking at, right, at that macro. And how does that changing this one thing, because, the head of surgery may come and tell me and saying we're changing the way we're using block utilization within the surgery. That has impact to the overall patient progression. And if we can get into that micro level to saying, if we make this change predictively, what does that do to the macro? Then I think we can start making some of that impact. But Anthony, you mentioned the layers of complexity to this, of governance, accountability, metrics to be able to be looked at, and tools to be able to assess that is an extremely complex solution to put into place. And I think that's where we are with patient progression right now, is the complexity of trying to get all of that. Now, we're making small steps. Unfortunately, I feel like the cost pressures are making bigger and faster steps against us in a lot of ways, right? And it's trying to keep up with that to get there. But I really feel like that predictive modeling is what's going to kind of start moving us ahead as well in those areas.
Very good, Dr. Rojas.
Yeah, I mean, I think just a couple comments on some of the things my panelists have said. I think, I totally agree as someone who is kind of a physician data scientist and builds models. I sort of definitely understand the value of sort of traditional machine learning, deep learning tools in this space. There are a lot of things that don't need something really fancy right now. You don't need a multi-step agent to predict, ER forecasting, for example, or ER boarding time. And I think in healthcare in general, I think it's been harder to forecast these things because the operational leaders, I think, need help from our IT data science team to sort of say, what if we could model out if you change X and that would lead to Y, potentially, and it may not always be right, but directionally it's correct. How would that help you do your work and plan? And I think the role that we have is sort of, IT data science people in the room is sort of help enable those sort of ideas to happen with the business and operational leaders, where, I would agree with Sunny that hasn't happened at scale, like in a lot of healthcare organizations, to sort of say, okay, well, maybe we can think about a tool that we can build in a week or two that may actually help with ER forecasting, for example. And so that's one thing. The other thing is, we talked about like tooling and in sort of governance, which I think is very important, sitting on some of our governance committees as well. But what I have noticed, and this is totally true, I think Sonny mentioned this, is that in the maturity curve, a lot of organizations, we may already have a tool like a voice tool. You may already have a tool that does, even forecasting to some degree. And people are just totally unaware in one island of the organization compared to the other island of the organization. And I think we have to do better about having almost a place you can go to say, okay, here are the things that we have in our tool stack. So you don't have to reinvent your wheel every single time. And so if you're someone in the OR and you're a urologist looking for some solution to help OR throughput, they're not going to be getting kind of the shiny object syndrome when we already have something very similar that they could turn on next week, right? And I think that is the part that we've been struggling with, is how do we make sure that we communicate with our operational, business, and clinical leaders on some of the stuff we have already invested in that they just sometimes don't even know exists, right? And so I think that's where we are now, is sort of trying to find that way to work with our operational business leaders who really know the process well, but also to make sure that they have either the internal resources like a data science team to help with a model, or to be aware of a tool that we already are using in another space that could be used for that same purpose, that may help move the needle in the throughput metric that they're trying to tackle. And so I think that's, I think more work has to be done, I think, across a lot of these organizations to sort of think through how do we make it easier for people to sort of know what's out there and how to start. And I think that the inertia of like getting a project off the ground, I think with our new governance structures, is often felt by my clinical colleagues is not worth their time. And so I think that's where we have to make it easier for them to do the right governance and the right accountability, but at the same time, not make it so onerous that they're just not even excited about innovating,
Yeah, I mean, and I think I understand the dynamic you're talking about, and I could picture an internal LLM type setup where all the inventory of all the IT tools are in there, and all the practitioner would have to do is describe what they're trying to accomplish, and it could service it. Oh, we have this tool. It's available for you, because right now, I bet you the process is the application. We do a lot of discussions about this. The application request comes in from a user, jumps through some hoops, right, of evaluation, has to, all of a sudden everybody's looking at it. Finally, it gets someplace where somebody goes, oh, we have that. But it probably takes forever for that to happen and get back down to the requester, where in your vision and what I'm talking about, that could happen in a minute, 2 minutes. Here's my problem. Yes, we have this. Here's who you go talk to, right? So, yeah, we got to find a way to make these things faster, so Sonny doesn't get all his requests bubbling up to his department of, can we have this, that, or the other thing? So, Warren, any thoughts on this latest banter?
No, I think, it's really about, I think tools in and of themselves are not necessarily going to get you very far. There is always the desire to chase after the latest shiny object in the healthcare space. I think there are some fundamentals that we all have to reconcile with, particularly in the patient flow space. So if you think about it, hospitals have existed for the longest time. And for at least a significant part of my career, patient flow has been that intractable problem that we have not been able to crack. One thing that I would offer is that one of the reasons we may not have cracked this nut is because of the way we think about the problem. In healthcare, obviously, with the emergence of AI and other computational approaches, we have not necessarily taken the lessons that have been widely adopted in other industries, including the logistics industry. If you think about it, hospitals are very complex systems involving lots of moving parts, the ED, the operating theater. I think Sunny mentioned, block utilization and schedules. That has a huge impact on the inpatient setting, the demand of beds, the matching of beds. And yet we think in healthcare that we are the first to encounter these types of problems. And so the first thing I would offer that we need to get right within the healthcare space in order to tackle the sort of macro patient flow problem is the way we think about this problem and the way we formulate this problem. I'll give you an example. We may have several tools deployed to accelerate this age-old notion of discharges before noon. And some of my colleagues, would say that this has sort of been my crusade to disavow healthcare of this notion of discharges before noon. In fact, there was a great paper written about 2.5 years ago about the things we do for no reason. I think that was the title of the paper. One of them is discharges before noon. And you could ask yourself, well, why discharges before noon? Why isn't it discharges before 11 o'clock or 11 a.m. or 1 p.m.? And frankly, I haven't had anyone give me a real compelling answer for why that is. And it turns out that really that particular aspect is really a proxy to say we'd like to get patients discharged earlier in the day, which is really a fine concept. That's really what we're trying to do. But we have anchored around building solutions and tools around this discharges before noon concept. And then we sort of look at the scoreboard and say, well, why isn't anything moving? Why isn't anything happening? Why isn't length of stay changing? Why aren't ED boarding times shifting? And so all that to say that to me, tools have to be guided by the actual framing and appropriate framing of the problem scenario, coupled with the right partnership in terms of governance with operational stakeholders who don't want to use another tool just for the sake of using another tool, but it has to be grounded in the foundational aspect of what it is you're trying to do, and does that actually lend itself to the outcome that you're seeking to achieve.
So that's a great point, and I think it reinforces the idea that we're driven by metrics. Right. So they came up with the before noon, and somehow it became Bible verse over time. And now we're trying to achieve this metric. But Sonny, as an IT leader, are you even having that discussion about the metric? That's not really your role, right? To evaluate whether or not they're going after the right metric. They just want you to help them achieve it. Wow. So what are your thoughts there? Is there any place for an IT executive to have a discussion about the metrics?
I think there is more and more now. And I think that as we are diving into, things still revolve around data, right? They are very much data-driven decisions at times. But the question of why you're trying to get to that data, I think, is starting to emerge more and more in the discussion, right? What are you truly trying to achieve, right? And if you really are talking about, to me, I think that's the maturity of your data analytics and AI, department that a lot of CIOs are now over, right? Is really talking through the data science of it and saying, what are you truly trying to achieve here, right? And I think that discussion and now the involvement of our executives that are starting to hear that more and starting to respond to it more are actually asking us to come to the table to actually drive the discussion of the why, right? Why are you trying to get there? And what is it you're truly trying to get to? And sometimes that discussion does really become to, well, help me understand on why you want to achieve this by a certain time, right? Or is there value in it? Or are we asking the right questions even? And I'm seeing that more and more happen. A lot of these actually, we're in the middle of a patient progression project right now. And a lot of those questions are coming to bear at this time as we're going through some of this, is to saying, why are we trying to achieve it in this metric? Is this the right metric we should be measuring? And I'm not saying data doesn't have a space in it, but you have to have the right, what you're trying to measure first before you get to that data space. so that you are making a decision that is truly informed through that process there. And I'm seeing that more. I think the IT executives are actually asking more of those questions and driving those discussions more.
Yeah, and I would assume it's a lot of how you articulate it, because Dr. Rojas, as a physician, that message might be received a lot better coming from you, questioning certain metrics that clinical leaders are trying to pursue and looking for IT support in pursuing. And that just may be better received for you to say, hey, why are we trying to get them out by noon?
Yeah, no, yeah. I mean, I don't know. Maybe I think it's maybe an asterisk there to that one. But what I would say though is the way I think about it is if you distill it down to really something really quite simple. There's really often for most of these throughput metrics or progression metrics, it's really a combination of access, cost, clinician experience, and patient experience, right? I mean, those are. I mean, if you distill it down to like key things. I mean, that's one of those things. Ideally, whatever you're trying to change makes all of those like a check, 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 check. Sometimes it doesn't, right? Like if I remember being a physician in the discharge before noon era, and I just thought like I cannot control like someone getting picked up at 11:55. The car is coming at 1. I'm sorry, I cannot. That was in an era when Uber did not exist, So and so I think there are some things that I think people, when we make metrics, I think we're both saying, I think Sonny and Warren elucidated this, is that it has to be sensical around what are the actual human and healthcare system problems that are just the nature of why a lot of these things exist, right? Like someone has to pick you up. Your insurance often sometimes makes it more difficult to get certain resources post-hospital discharge, for better or for worse, right? And so I think when you have a metric that doesn't incorporate some of the realities of what people are experiencing on the ground, it becomes something that people just aren't going to buy into culturally. And so I think you do have to think through like what metrics can you think through as a organizational leader, either in IT or in other positions of leadership in a healthcare system that will help your health system overall, but ultimately are patient-centered and clinician-centered in a way that isn't going to be totally disregarded at face value. Because if ultimately a lot of these metrics require really people on the front lines to really make actual decisions in the morning or in the afternoon or at night a little differently than they might normally do to really move the needle, right? So I think the ones I have seen, the metrics I've seen been successful, the organizations I've been a part of have really been sensical across a lot of domains. And people are like, yeah, that makes sense. It's good for patients. It's good for, good for them, good for the healthcare system. And let's do that. Like that makes a lot of sense. And I think if you get clinicians behind that sort of ethos, they're usually, well, I will say some of us are more prickly than others. I think generally speaking, I think, as a whole, I think people realize that if this will help patients and help the health system, let's do it.
All right, Warren, let's go ahead,
Anthony,
please.
could I just pick on that thread that Dr. Rojas mentioned? Because I think that's a really important point. I think the framing of the intersection of metrics and technology, typically in patient flow, tends to be more of a fiscal or a financial lens. And when you start with that, when you simply say, well, we need to do this because there is a cost imperative or a fiscal imperative, you've essentially lost the entire constituency that needs to be orchestrated in order to drive patient flow. That sort of framing does not resonate with physicians or nurses. And so I think what Dr. Rojas is pointing out, I think is really important for all of us to take to heart, to say, how do you frame this and how do you characterize this in a manner that is going to motivate them to actually organize and orchestrate differently than simply saying, we need to do this because that's what the finances call for. It isn't an invalid point. I mean, ultimately, healthcare is a business. It's certainly a valid point. But if you're trying to motivate the entire supply chain of individuals on the front lines to do the things that we need to do to take care of our patients and to get them along in their journey, the framing and the argument has to be different.
Very good, very good. All right, I want to touch on another thread here. And Sonny, you had mentioned this before. This is something sort of I call it the leaning in concept. It's something that seems to be especially important for IT executives uh, as they need to support different areas of the health system where they need to develop a deep familiarity with the operations that they may not have intuitively, such as imaging. If you want to move towards enterprise imaging, really need to lean in and learn imaging workflows, very complicated revenue cycle management, things like this. You mentioned earlier in the webinar this idea of deeply collaborating with operations. If you're going to move anything in this area, it makes total sense. It's so intricate, and you don't know if you're not a practitioner the deep workflows here and the intricate workflows. So it's another area to me where, as an IT leader, you have to lean in and learn to be successful in supporting them. And I'd like your thoughts around how you have or how you continue to want to be deeply exposed to these workflows, to understand them, spend time with the practitioners so that you can help them.
Yeah, I'd say it's critical. It's less, in today's, it's less about the tool. I think it's about the operational discipline, right? You got to have that discipline, and to have that discipline, it really becomes hard for you to truly know how to function with the tool without getting deeply involved in what that operational discipline should be. And so I think rounding and spending time in the shoes of those folks is becoming more and more critical for tool development. And it is something that my leaders and I are really looking a deep look into, to saying, how do we actually get and spend the day in the life of, right? Let me understand your world, and really be part of your world there, so that I truly understand what you're talking about. Because when you really look at it, and we're trying to evolve with different methodologies. So whether you look at lean, whether you look at agile, whatever you're looking at, to being able to help with some of the development of what you need to get to, key part of that is honestly living in the life of the shoe of where those operational areas are, right? You want to be able to put those sticky notes and really work the workflow of saying, how do we get to the tool being effective for you, right? And part of that is just spending the time. And the challenge is within the IT space, and this is being very candid, is that we're being pulled into these operational areas with rightfully so, with a lot of time that's needed, while we're also trying to battle the time that is needed for all the other things and the pressures that we're brought into. And the in some more days I feel like a COO than I do as a CIO, because I feel like I'm getting deeper and deeper into the operation side of things. But the payoff is so much better as well, because when you do get to that solution set, I feel like you get buy-in. I feel like you get more of an effective, actually, delivery, and you can actually be able to speak to when things are off track on exactly how to bring them back on track. And so I think that world is shifting dramatically for IT right now.
100%. That's really great stuff. Dr. Rojas, you want to continue on that a little bit? I've heard the term embedding before, as IT folks talk about how to support operational areas. And there are different, I guess, ways you can do that, technically speaking, and different levels of embedding. But it goes to that idea of deeply understanding the workflows that you're supposed to be supporting. And then, as Sonny mentioned before about the dynamic where you really have to try and understand what's being requested rather than just, oh, you want this, we'll get that. No, well, what do you really want? And that goes for applications, and that also goes for requests around reports or different pieces of data. I did an interview with a data leader who said one of her biggest things she operated by was, we're not order takers. So when you come in, you want to request a piece of data or a report, we're going to have a conversation because we want to help you. We don't want to do all this work and give you something and it's not actually what you wanted because we didn't take the time to understand. So on many different levels, it seems to be critical to more deeply support and integrate and embed with the operations. Your thoughts?
Yeah, I totally agree. I mean, I think we are in early phases at Rush, just sort of thinking through, I guess, what our CIO is calling sort of a tiger team, where we would have, I think it's equally important to have both, clinical engineering talent. And I really do think one of the biggest unlocks for a lot of those teams is sort of a human factors person, right? Someone who really understands, he can map out a process map, can, do, I guess, in the lean methodology, a Gemba walk, and really think through like what the process is. And I think with a small, nimble team, especially on it doesn't have. I think one of the misconceptions I think I've been trying to dissuade some of our other IT leaders is that you're gonna need an army of 15 people. I think with 3 or 4 people who really kind of understand a workflow and really dig into, say, rev cycle, throughput, you can really make a big difference. And I think that's what I'm really excited about now is that how do we use some of the new tools we have at our disposal, and sort of get a working process to help that improve and kind of iterate, kind of like a classic quality improvement process, right? You may not, your first POC or tech-enabled process may not be perfect, but I do think that as you iterate in a much quicker fashion than we could before with a smaller team of individuals, I'm really excited about what that could do. And so, I'm going to be one of the people on that team helping to sort of do some of the engineering stuff because I love the code and I love to sort of apply my clinical hat into the domain of engineering, but also work with others who really understand rev cycle or other processes I'm not intimately involved with, but I'm really looking forward to sort of digging into some of those sort of silo domains in healthcare that I think people really want to learn how to help them, and they have to help us help them, right? And that's totally what you're talking about.
100%, 100%. Warren, what are your thoughts?
Yeah, no, couldn't agree more with what both Sunny and Dr. Rojas have just said. Cross-functional collaboration is really the name of the game here. To think that anybody can just go at it alone, I don't think you're going to get very far, particularly in a complex problem scenario like patient flow. What I would add is there's really 2 aspects that we try to embody in our innovation center. One is leadership buy-in. You need cross-functional leadership buy-in to facilitate and to create the environment and enable individuals to be able to learn from each other, to understand a day in the life of, whether it's the provider, the nurse, the care manager, so on and so forth. I think that takes a level of enablement from leadership to allow for that. The second aspect of it is picking the right phenotype of individuals with particular expertise. Not every provider, and I say this with the kindest of intentions. Some of my closest friends and colleagues are physicians, but not every physician wants to dig into the details of trying to figure out a particular solution or how to think about a problem differently. What they're really interested in is, hey, I've got these barriers, I've got these problems. Come talk to me when you have something that's going to make my day easier. And that's true across the board. And so it's really critical. We spend a lot of time trying to figure out how to tap into the right types of individuals, because my guess is the Dr. Rojas phenotype is not the sort of common theme of individuals who are trained to take care of patients. And so bringing some of those individuals along and putting them in an environment that enables them to sort of experiment to whether it's lean or agile or any other of the frameworks. You need some level of acceptance of fault tolerance, where the first thing you try or the second thing you try is going to fail, and maybe fail miserably, but you're going to get up, you're going to dust yourself off, and you're going to try again. I think that type of resilience is some of the core tenets, at least, that we have tried to focus on in order to create something meaningful and sustainable.
Excellent. All right. Warren, do you have a question for one or both of your co-panelists?
Yes, I know this is a technology and an IT focused webinar, and I think we've talked a lot about the the potential for technology here, I find that one of the biggest barriers, particularly in the patient flow space, is cultural and mental valleys that various constituents encounter. And this is true in 2026. I feel like sometimes we're talking about the same things we were talking about 10 years ago. And so the question, I guess, really honest and sincere question to Sunny and Dr. Rojas is, how do you all think about some of the cultural aspects and the mental valleys that, really smart people who are trained, well-trained, and focused on taking care of patients, how do you move them in terms of alignment with achieving better access to care, right care settings, while perhaps abandoning some of those long-held beliefs that they have grown up with and perhaps trained with?
Dr. Rojas, let's start with you.
Yeah, I'll fall on that landmine first. I think it's a great point. I do think that as as both a physician and an IT person, I can kind of see the both sides of the coin, if you will. And I do think there are a lot of lessons learned through your medical training that, for better or for worse, are sort of how things are. And I think what I have found, at least in my own experience, I'll take the use case of ambient, because that's probably the tool that has affected most of my colleagues in some way or another, is that sometimes in a lot of the first times I used ambient, it went horribly wrong. Like it didn't work. But then what I told them was like, hey, I am a physician who loves this technology. Let me help you figure out how to use this better. And with some hands-on pragmatic advice, and I think that's partly what it takes for a lot of these sort of transformations. It has to be a one-on-one or a small group session to sort of ideate on how this new technology can work for you, to your point, Warren, about like how do you solve a problem in my own current workflow. And while I haven't been 100% successful in my, we'll call it ambient 101 talks, if you will, I would say half of the time I'm able to get the clinician to give it another shot, and many of the times they'll actually keep on using it. And I think my overall hypothesis is, and I think especially among the clinicians that are training now and the ones that are being educated now, we really have to think about how our world is going to change with the technology we're going to use. And right now, I would say the vast majority of curriculums that we are training under, our nurses, our physicians, our physical therapists, pharmacists, don't have enough AI kind of literacy and upskilling that they're going to need to really be more engaged, inquisitive people on those sort of teams, working with Warren and his team to sort of really know that it might fail the first time or the second time, and to have enough of the buzzwords that when an engineer talks to them, their head's not going to explode. And I think that's that sort of cross marination of like different skill sets, like Warren mentioned, I think is to me really going to be the unlock. Once people figure out how to do that within an organization, even within a small team, and then maybe scale that across different types of educational platforms, nursing school, medical school, with a combination of innovation locally, but also probably coming down from like the AAMC and others, I think we're really going to hopefully have a little easier time in the next 5-7 years than we're having now with the current generation of clinicians we're working with.
Great stuff, Sonny.
I would say focus partnerships. Really, honestly, it's coming down to what you're trying to resolve or what you're trying to get to. And really partnering where you feel like there's going to be movement. There are leaders out there that have a voice, and folks listen to that leader's voice. And we've been very targeted on who we bring in on certain projects because it's not that that person has higher skills or more of that, capability of actually taking on the tool. It's how they convince the others to go on that journey, because it is a journey and you are going to have naysayers. There's no doubt about that. There are folks like you mentioned, Warren, that you are going to have those folks that are going to want to be pulled in just because they want to see at the time that it's going to impact them, and it's either a yay or a nay, and it's a pretty quick yay or nay, because if they don't see what they like, they're out quickly, right? But it's the person that can rally them along the way, right? And so we become very focused on targeted and in trying to pick the right people to take us along in that journey with us, right? And so it's a lot of partnerships. I don't think we're going to be having a different discussion in 10 years even. I don't think this is going to change. It may change on how we use those partnerships and where we pull on and where we pull down, or how quickly we can get that information out, because we got tools to be able to do so. But at the end of the day, we're humans, and I don't think we're going to. Culture is a forever evolving thing, right? It doesn't have an end goal. It's a journey that you just keep going on. And to me, it really comes down to the way I've seen some of the successes is coming from those really focused partnerships and how we use those.
All right, very good. Sonny, do you have a question for one or both of your co-panelists?
Sure, I'll go maybe a little bit more onto the IT side of things, and maybe I'm hearing a lot more of this push for predictive analytics and looking at the throughput through that foundational work of standardizing workflows and data quality. And where are you seeing your organizations in that journey? And are they getting that sequencing right, or are you seeing that there's a better way of sequencing things with that?
Warren, let's go to you first.
Yeah, so absolutely, Sunny. So, I think there is a huge role for predictive and prescriptive analytics, including AI, but also other computational techniques like simulation. When you're talking about a complex environment like the hospital, with all of the moving and interconnected parts, we have spent and both from a technology standpoint as well as from a cultural standpoint, sort of migrating individuals and care teams to use a lot more of these as decision support aids as they think through the problems, the micro problems within the entire spectrum of patient flow. So absolutely, I think, things like it used to be that you would ask a provider to enter an expected date of discharge. And if you talk to most providers, they would tell you that it was an educated guess at best.
Yes.
We now have AI tools that can do that. Now, I will still offer that, the expected date of discharge, is that the right metric? We can debate that. But the point is that we can certainly use a lot of the technology-enabled outputs to reduce the cognitive burden of our frontline teams. And I think once they get over that cultural barrier, absolutely, these things are going to be critical to the enablement and to the improvement of the overall patient flow space.
Mm-hmm.
All right, very good. Well, we are almost out of time today. So I think what we're going to do is go for a last round of advice. So what is your best piece of advice to people trying to tackle the challenge we're dealing with today? Sonny, you want to drop any last minute wisdom on us?
Yeah, I still believe truly, honestly, start with the operational clarity. I think that is so critical into anything that we're trying to do before we put a technical solution in place. I feel like we talked about that partnership. We've talked about shadowing and be living the life in the day of the operational areas, understanding what they are truly asking for. And that clarity is I think, is such a gift to us when we really look at how much time we land up putting in the forefront of that versus how the result we get in the back end of that. I think you spend more time the other way around when you're trying to recourse and recorrect because you didn't get it right, right? And so the investment of time, I think it's a cultural shift in our world of how we think about it, right? And I'm seeing more of that adoption, but I still think we're young in that journey of that cultural shift of looking at how do we get that operational clarity in the front end of things to actually deliver in the end. We still are very programmed, especially in IT, I think, very much of saying, give us your problem, we'll give you the solution, as opposed to trying to understand the problem properly before getting to the solution. And so for me, my parting advice would be really start putting that rigor in that operational clarity, because I think the fruit that you bear from that is really, really powerful.
Brilliant. Thank you, Sonny. Dr. Rojas, your final best piece of advice today for the audience regarding, the overall framing of the issue.
Yeah, no, I'll sort of echo what my co-panelists have said. I really do think, as the clinician on the panel, is just organizing, when you're in IT, really think through who are the partners you can bring to bear. And I think oftentimes your clinicians or your business leaders kind of at the front end of that work will really help your team and able to pick the right solution, to pick the right problem to solve, and then ultimately the right metric to track, right? So I think it's a combination of a priori having what is the problem I'm trying to solve, who can help me figure out how to tackle that problem locally, who has the best knowledge about it. And then that's when you can solution a tool or build a tool, or figure out a combination thereof to help maybe move the needle there. And then obviously what I'm really passionate about is actually studying if it worked, right? Like, don't forget that when you turn something on, it may not work. And so you probably should track, how you're doing it month 3, month 6, and then, have a lot of our solutions may have to go to a graveyard, and I feel like we don't often do a great job in IT or in healthcare of sort of turning off things that are just no longer effective.
Well, Dr. Rojas, you just gave me an idea for another webinar, so I'm going to have to reach out to you on that. Decommissioning. That's a good one. Warren, we'll give you the last word. How do you want to sum it up?
Yeah, no, I agree with everything that Sunny and Dr. Rojas just identified. I would add institutional leadership and enablement is key to success, particularly in the patient flow space. I think if this is thought of as just another initiative with a few valiant souls trying to embark on this crusade, I think it may work for a period of time, but I think it will fizzle out. I think patient flow has to be an organizational imperative, particularly with all of the externalities, the market forces, the dynamics that we live in healthcare. And so without that, a lot of the other things are not necessarily guaranteed success.
Very good. Very good. All right. Well, that's about all we had time for today regarding continuing education. You could use the link I sent out in the chat box to download a certificate of attendance. There are also links to today's sponsor, iHarbor, the University of Maryland Medical Systems Innovation Center, and some other resources we put out there. I want to thank our panelists for spending their valuable time with us today. I want to thank iHarbor for making the event possible and you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you.
Thank you.